Today on The Operators, we have Ada, who is a medical director. We spoke about her long career as a medical director, but also her immigration story coming from Africa to London to America and the differences between all three. So hopefully you enjoy. What's your journey to kind of getting started, your work career to where you got to today?
Yeah. So my journey has been very uneventful in the sense that I always knew I wanted to be in healthcare right from when I was a kid. But I was actually going to be trained as a physician, and I went to medical school for about a year, and I decided it wasn't for me just because I cannot stand the sight of blood
Mm.
and I can't needles. So I decided to become a physical therapist. So I trained as a physical therapist back in West Africa. Worked at the Naval Hospital there for a few years. Then I went to England to work. I was working in England at different hospitals as a traveling therapist, and I got recruited to come and work in the US. And when I came to the US, I first landed in Detroit. I actually ended up working there for 26 years. And that's where I got into leadership. I was working in a hospital in Detroit when I just got a call from a colleague who said that somebody who runs a private practice wants to talk to you. And we went and had dinner. And before dessert, he offered me the directorship of his clinic in one of the suburbs. And I felt, oh, this leadership thing is very easy.
Mm.
Which was I fooled because I got the job so quickly that way. Um, but I've loved it. I've loved healthcare leadership. I've been in it now for close to 28 years, almost 30 years. And it's one of those things I tell people that it's very, um, it's like whiplash because you go in one direction and then you're shoved back to another direction, and it constantly evolves and changes. So if you want to be in healthcare leadership, you can't stick to one mode, one single way of doing things.
Yeah, and it's if you look at your LinkedIn, it's very interesting because it's like these huge career like like you're not like constantly rotating like, oh, I worked here, worked
No,
here, worked here, worked
yes,
here. It's like
yeah,
9 years at one place, 15 years at one
yes,
place,
yeah,
9 years at one place, like boom,
yeah,
boom, three big
well,
blocks.
yes,
Which sometimes I look at people's LinkedIns on this show and I'm like, oh man, it's just like jumping everywhere. And
everywhere,
I'm
yeah,
like, oh.
yeah.
So what do you think? Why is that, would you say? Like why have you worked so long for these organizations? Is it a testament to yourself that people want to keep you around, would you say?
I'll say it's both that and the fact that I've been fortunate to be able to do different things within the same role, whether it's leading people, leading change, leading projects, building coalitions, um, responsible for business results, growth, budgets, all that, all those I've done within the certain role. And I think that's led to the fact that I have to jump to somewhere else to get those opportunities.
Hmm.
Yeah.
Would you say then that every once in a while you do kind of need to shift to another place to climb the ladder?
Well, it's not climbing ladders per se, because when people think about climbing ladder, they think of getting a promotion, getting a new title. Um, the titles for me are not as important as the satisfaction I get from the role where I am, because I believe you can lead in any role that you have, whether you're a director or you're a staff person or you're a vice president, you can lead in that role if you make it that way. So I when I don't get opportunities to do different things, when you're just doing the same thing day after day after day, then that's not interesting. But if there's a project I can lead, whether it's an international project, whether it's developing a new program, whether it's opening a new location, all those are the things that give me satisfaction within that role.
So then, as a director of operations, like what does the day to day look like for you?
Um, I provide leadership, direction, oversight of many things. So whether it's customer service, budget, the people management. So under me, I actually have four managers who do the day to day, and they report up to me, and I meet with them all the time. So I see myself more as a developer and as a helper in where they need assistance, which is either getting through a bottleneck, of a certain operational initiative they're trying to do, or whether it's taking responsibility for customer service issues, coordinating clinical initiatives. In the healthcare world, we're always looking for the next best initiative to serve patients, make quality, safety. Those are big topics in healthcare, and of course growth, because you want to be able to see all the patients that come to you for care. You don't want patients to have to wait for weeks to get it to
Mm,
to see a healthcare provider. So I think that's something that a lot of healthcare leaders tackle on a day-to-day basis: quality, safety, and cleanliness of getting patients in. So I act as kind of the overall, for lack of a better word, executive to my
mhm.
managers to make sure that we accomplish all that for all the patients, the spectrum of patients we see. We see patients in the outpatient locations, we see patients on admission in the hospitals, we see patients who go to nursing homes, we see patients who are ready for home health. So it runs the gamut of patients.
Yeah, and what are all the services you offer at Dignity Health? Like it's quite a large organization. It's pretty
It
big.
is, yes, Dignity Health is one of the biggest nonprofit health systems in the country. They're located in about 24 states or so, 140 something hospitals, and about 2,000 ambulatory care centers in 24 states. So it's pretty big. Um, and we offer, I'll say, everything. I think we do everything from transplants to simple back pain to surgeries to stroke patients to respiratory problems to women's health, men's health, OB-GYN. We do everything. Yeah.
Yeah. So you're based in Arizona, though.
Yes.
Is that where like the head office is, or do you just
No, no. The head office for Dignity Health is in Chicago. So it's
Mm,
actually Dignity Health is part of Common Spirit Health. I don't know if you've heard of Common Spirit Health. It's that's the umbrella organization, and under Common Spirit Health is Dignity Health and CHI, which stands for Catholic Health Initiative. So
mhm.
we are both under Dignity Health. um, Common Spirit's headquarters is in Chicago, and then you have all the other states that are part of it. So California, Colorado, Arizona, Nebraska, Nevada, um, Kansas, about 24 states. Yeah,
Yeah, it's quite large. So then,
yeah,
what does like a daily day look like for you? Like your average day, would you say?
yeah. The average day could be anything from attending patient safety meetings to talking about the budget with the financial
Hmm.
folks to dealing with a patient complaint, maybe a patient that wanted to get in and nobody called them back on time,
Mm.
um, to providing leadership for my managers, doing some training, some leadership training for them, um, making sure we are compliant with all the laws because we are governed obviously by the healthcare laws, both federal and state.
Hmm.
For instance, yesterday we had a visit in one of my hospitals from the state of Arizona who came to survey because um, they just popped in. Sometimes they don't need a reason, but they come like that, and they wanted to find out how I did the orientation for new therapists in the department. So
Mm.
we had to put a, and they just picked a random therapist on that they picked the name from from the list. And we had to provide them the file for that therapist, and they went through that. So that ended up taking most of yesterday.
Mm.
Um, it wasn't planned. We just got the message about 6:30 in the morning that they were showing up for that. So that's kind of how healthcare is. You have your plans, but then those plans can get disrupted. And when I said at the beginning of the show that it's like whiplash, you have to pivot and do something else.
Yeah, of course.
Yeah.
No, I mean, definitely like, and from my perspective, working at a startup, I mean,
Yes.
I've
Oh
been
yeah,
there,
I'm
done
sure.
that.
I'm
I'm like
sure. Yes.
everything. Like people ask me what my position is in the company. I'm like an everything
Yes.
guy.
Exactly.
Podcaster, customer support, sales
Yeah.
and
Yeah.
marketing. Yeah. Um, so you mentioned going from West Africa to the United Kingdom and then moving to America. I was actually in London not long ago, a couple weeks ago. I was in London.
Okay.
Um,
Well, I used to live in London.
I was in Kensington and I was laughing. There wasn't I was with my British friend and
Yes.
everyone in Kensington was American. Like just every single person. You walk into a restaurant, it's full of Americans. And we
Yeah.
went to this sports club, it was full of Americans. And I was laughing. I was like, I think you're the only British guy in all of Kensington. Everyone was American. I think there's a lot of, I noticed there was a lot of wealthy Americans in London. And I feel like it was sort of like they wanted to be like aristocratic. It was like their chance
Yeah.
to
Yeah.
go to
Yeah.
London, drink some tea, and kind of
Yeah.
whatever. But yeah, that was my
Well,
vibe.
you stayed, yeah, well, you stayed in the kind of aristocratic area,
Yeah.
Kensington. I know Kensington very well. So Kensington, that's near Buckingham Palace. So obviously it's close to royalty. But next time you go, venture out of that, venture to the north parts to Enfield, to Brentford,
Mm,
or you go west to Ashford, go to West Ham. So London is so diverse. It's incredible. You can walk down the street, maybe on Oxford Street, and hear about 20 different languages within
yeah.
1 mile.
Yeah, of
Walking
course.
one
Yeah.
mile.
Yeah, definitely. So what was it like then to go from Africa to London and then to come to Detroit? Like, what was that like
Yeah.
experience like for you?
Oh, yeah, very, very, very different. But going to London to work wasn't actually such a big cultural change because I tell people, when they ask me what my culture is, I said I'm like a mutt, so I'm very African, I'm very British, I'm very American.
Mm,
I have all those. And the reason is, even though I grew up in West Africa, I actually lived in England as a kid with my
mm,
parents. So we lived in Manchester and we lived in Bradford. So I've always had those British roots in me. So going to London was like a second home. It wasn't much different from West Africa. The big change was coming to the US, and it wasn't intentional that I was going to stay. I thought I was only going to stay a couple of years and then go back to England. And here I am, 30 years later,
yeah.
still in the US. Um, I went to Detroit for adventure. I wanted to see what it was like. I wanted to know what it felt to work as a therapist in the US. And I fell in love with it and I made a family when I was here when I moved. So my twins, I'm mom of twins. They were born in Michigan.
Mhm.
So and that's the reason I've stayed.
Ah, okay. That was
Yeah.
my next question. What made you stay so
Yes.
long?
Yeah.
And what was kind of the culture shock from moving to the US from London?
From London, it's oh, I'll say just the way of thinking, the expressions, you might have heard that expression with the British, the stiff upper lip.
Yes,
When
yes,
you
yes. Mhm.
something is bugging you, or when somebody has upset you or somebody has done something to you, you keep that stiff upper lip.
Yes.
You just accept it. You don't talk, you don't complain. And then when I moved to Detroit, everybody talked openly. Everybody
Yeah.
complained. If you brushed them, on the shoulder, they'll tell you about it. So
Yeah.
that was the biggest shock, I'll say.
Yeah, I can imagine. So then going back to your career, like what do you think the next couple of years look like for you in your current position?
I would like to explore doing more international projects in
Mm,
my position. I've done those for a while, and by those I mean whether it's consultancy or helping with third party advice or actually one-on-one direction and help with projects to do with hospitals, healthcare outside the US. I actually started doing a bit of that before COVID hit in
mm,
2019, where I wrote some protocols for rehabilitation for a hospital in the UAE. And I ended up meeting with them because they came to Arizona to meet with us, not just me, but those of us who were involved in the project in Dignity Health. So that was very, very enjoyable to do. I also did a project where I wrote the proposal to open a rehabilitation hospital in Shanghai. And believe it or not, I was slated to travel to Wuhan in 2020. Um, and that trip was being planned in 2019. And as you know, Wuhan was, site zero for
yeah,
COVID.
ground zero
That's where
for it,
COVID
yes.
started. So,
Yeah.
but I was supposed to go there, so I couldn't believe it, you know,
Well, I guess the trip
when
got
COVID.
canceled,
Oh, the
depending on
trip
when it
got
was booked.
canceled. Yeah, yeah, it got canceled. The lady I was working with actually went to Wuhan in September,
Mm,
and she was there for a couple of weeks. And I was going to be going with her about 6 months after, which was around February or so, or March of 2020. And then, of course, we all know what happened.
yeah, of
So,
course.
yeah, the trip was canceled.
So, what was COVID like then for you in your position?
Oh, it was very, very challenging. And I think um, there's a sense among healthcare leaders that the healthcare leader who leads during times of no conflicts, when everything is going fine, is not really the type of healthcare leader you want during times of crisis, which COVID was.
Mhm.
COVID was something none of us had trained for. So things changed almost every day. We used to tell the staff that I might tell you this is what we do at 9 a.m. in the morning, but I might come back to you at 4 p.m. in the evening and tell you something different.
Mm,
Because
yeah,
the policies have changed, whether it's a new guideline coming out from the CDC or something new. So for leaders, my role during COVID is getting the information to the staff so they could have the information at hand, but also knowing when to hold their hand and comfort them, because a lot of the frontline staff were dealing with a lot of death that they typically don't deal with.
Mm.
I had therapists who go and see a patient in the morning, and in the evening the patient has passed away.
Mm.
So it was a lot of phone calls, a lot of consoling, a lot of supporting. If somebody wanted to take time off because they just couldn't cope with what was going on, we worked around that. Um, and working through that shortage of staff, but also dealing with the public, because the public also needed answers. They didn't know what was going on, so they came to us for answers. So it's lots of finding information, delving into information, doing research to make sure we got the things that people needed, both patients and staff.
And yeah, like during COVID, there was probably a lot more death than people were used to. Like, how do you
Yes,
deal with death at a hospital? And
it was. I mean, I'll just say plainly that it was an awful time,
mm,
but we had to do it. You couldn't put your head in the sand and pretend it was not happening, because it was. So there were even stages during COVID when um, the funeral homes would stop coming to the hospitals to pick up the bodies because they were full. So we had to devise places in the hospital where we could keep some of the people who had passed away because the morgue was full. So things
mhm.
like that people don't even realize outside healthcare. Um, we had to have tents at one time in the parking lot for just regular type patients who were not COVID patients to stay in, because the COVID patients were taking up all the floors and we had to isolate them. Um, before you go into a patient's room, you have to suit up almost, those suits you see for the NASA scientists going into space.
Yeah,
That's
yeah,
kind of how most of us looked going into a patient room, because you had to don all that gear to get in. And then when you come out of the patient's room, you have to take it all off. And then you have to put it all on again to go and see another patient. So it was just physically exhausting and also mentally challenging.
yeah, yeah. Well, I'm sure glad that's over. Um, what what is the admin side like for you? Like around like patient intake, I'm always curious about, and then I'm always also curious about insurance. But let's start like, what's your kind of perspective on scheduling and intake at clinics? Because there's a lot of people always complaining that hospitals and clinics kind of are not doing a very good job at patient intake.
Yeah. It varies, so when a patient, so I'll give you an example of the ambulatory setting. So this is when you're just going in as an outpatient. So you go in, you have your procedure, you have whatever you've gone in to do your therapy appointment, and then you go home. So that's a lot different than if you're going to be on admission in the hospital. So if you're going in and as an outpatient, obviously the first contact is usually by either phone or email or fax or walking in. We take patients all those ways, and because America is a country that we don't have universal health care, everything is insurance based. So the folks doing the intake have to verify the insurance. And that's just to protect the patient, to let the patient know what their insurance covers and what the insurance does not cover. Because as you know, there hundreds of different types of insurances that cover different things at different ranges and different scales. So that's one. And I totally get when patients say that it's very um time consuming and very hard, but it doesn't need to be. That's one thing that I try to work on with the front desk staff who work for me, that we need to make that process as painless as possible for the patient. The patient is not going to Disney World. If you're going to Disney World and you stand in line for 1 hour waiting to get on the ride, you're fine. But if you're hurting and you're in pain and you're coming in to see the doctor or the therapist, you don't want to be, moved around. You want to get your answers right there and then. You want it to be painless.
Yeah. And then, you touched briefly on insurance. Like, what's your thoughts on
Yeah.
the insurance landscape and all that stuff?
Oh, I think we can be here all day if we
Yeah,
talk if
you
we talked
can.
on about insurance. I've seen the other side. I have a different perspective because I used to work in England, and
Mhm.
England is it's universal healthcare. And I
Yeah,
hear the other side of the argument where they say, well, but you have to wait for 6 months to get your total knee replacement. And my answer is always, yeah, that's right. You wait for 6 months. But what would you rather have? Wait for 6 months, get your knee replacement and don't owe anything, or get your knee replacement in 3 weeks and owe $50,000,
yeah,
that you'll be
yeah,
paying for the next 10 years. Um, I know the option I would rather choose.
yeah.
um,
I
so
think
the insurance, it's out of
I've
control.
seen it in Europe, where Europe is kind of going more towards like medical tourism, where people are
Yeah.
doing cash pay, but they'll go
Yes.
somewhere else, wherever that place be.
Yes.
And
Yes.
I don't think the US has like crazy. I mean, it must happen to some extent, but I don't think there's a huge amount of people going to like Mexico to get medical treatments and stuff. I don't think
Uh,
so.
Um, I've heard. I don't know the numbers, but I've heard about that too. I've heard people going to Mexico. I've heard people going to the Caribbean.
Mhm.
I've heard people going to India and China.
Yeah,
So yeah, so I was talking to somebody a couple of years ago, and they said the cost of their airfare and hotel and the cost of the surgery they had in India would have been less than it would have cost them here in Arizona.
yeah.
So, but like you said, I don't believe it's a large number, but I know people are doing it. Yeah. I
Mm.
don't know what the stats are.
And then, so you think that what are your kind of key takeaways from the current insurance landscape then?
My take on the insurance landscape.
Yeah,
Oh, I, to be honest, I think it's out of control.
yeah,
And it's not that people working in insurance are bad people. It's just the system that we all have to live under. So the purpose of insurance is, when you buy your insurance as the patient, or it's bought for you by your employer, you are guaranteed certain things. So I think the frustration comes from patients who expect that, I pay for this insurance every pay period, every paycheck, something is taken out, but the insurance also decides that some things are not going to be covered based on what their criteria is. And that always moves, it always changes. And I think that's where the frustration comes.
yeah. So, so then what do you think the future of this is kind of the last question, and we'll wrap it up. Like, what do you think the future of US healthcare looks like based off everything that you've seen in your career?
I, I, what I think and what I hope are probably two different things.
Yeah.
What I think will happen is, I don't think there's going to be much change, at least in the next 10, 15 years, than what it is now. What I hope will happen is that we get to a point where almost everybody in the country is covered by some form of health insurance
Mm,
because one of my um, philosophies is health is wealth. If you're not healthy, you can't do anything. You just talked about going to London. You couldn't have done that if you were not healthy, you know.
yeah.
So health is wealth in my opinion, which means that we all need to be healthy in some form, and we all need to have the possibility of being healthy. So whether it's sponsored insurance through your employer, whether it's provided by the government, whether it's private pay, it can be a combination of different things. But I think we've done a poor job in the US so far of keeping people healthy.
Mm,
And that's why we see a lot of increase in chronic conditions, so whether it's kidney disease or asthma or heart problems or, lung problems, those things, when they become chronic, end up costing more down the road. And if they're dealt with earlier on, when we have preventative services, if you have insurance, you go and have your preventative service, and the doctor can tell you, well, Benjamin, I think we need to start this regimen so this doesn't develop into something serious. Then it's cut right there at the beginning. But if you don't have that insurance and you don't see the doctor and you don't know, and 2 years from now it develops into something more serious, then you need to go to the hospital, which costs a lot more money.
yeah. Well, thank you so much, Ada, for coming on the show. I really appreciate it. I'm sure you're busy.
Oh, that's fine. It was nice chatting with you.
Yeah.